An expert review of the Sonopartogram and the prediction of labor outcome. The Partogram history. Emanuel Friedman studied the progress of labor in the 1950s, originating a graphical representation of an ideal labor, defining its normal length and duration. Labor progress was assessed using rectal examinations of the cervix and recorded in centimeters of dilatation per hour, depicted as a sigmoid curve, as seen in the image, which became known as the cervicograph. Most maternity providers monitor progress of labor according to the partogram developed from these Friedman's curves. In 1972, the partogram developed from the cervicograph to record additional intrapartum observations, not just cervical dilatation. Later in a further work, an alert line was added to the partogram and expressed as a straight line rather than curved. This line represented a progress rate of 1 cm per hour, hence a line showing slower cervical dilatation would cross the alert line. The next stage of partogram development was the introduction of an action line, 4 hours to the right of the alert line. This line was developed to identify primary inefficient uterine activity, and a speedy intervention must be made. In 1988, several developments have been made to the original partogram. The World Health Organization (WHO) produced an agreed standard format of the original partogram, which is a graphical recording of labor progress and the condition of a mother and fetus. In 1994, the WHO recommended the partogram to be used to define slow progress of labor through alert and action lines. In the top panel shows fetal observations and labor progress, while in the bottom panel displays maternal medical information. The alert line, which is highlighted in orange, depicts the slowest acceptable labor progress, while the action line highlighted in red, which needs prompt management by a medical team. In 2007, several adaptations to the original WHO partogram have been made. The left image is the simplified partograph. It is developed to simplify the chart representation of cervical dilatation against time and track the rate of progress. It is used in active labor beginning from cervical dilatation of 4 cm plotted along the y-axis and time in hours along the x-axis. The junction between the green and yellow areas represent an alert line, where if crossed, a review by a medical practitioner is recommended. The junction between the yellow and red areas represent an action line. When this is crossed, abnormal progress in labor is inferred, and medical interventions is recommended. Maternal observations and labor information are recorded beneath this partograph. Later, in 2018, the WHO updated its recommendations on intrapartum care. It included a new understanding of the individual variability of the progress of labors, resulting in good perinatal outcomes. The WHO recommendations recognize a global shift towards improving experience of childbirth, and this necessitated the design of a new labor monitoring tool, the WHO Labor Care Guide. An interactive partogram was launched as an app in 2019. It is an example of an electronic partogram in modern use, as seen in the right image. An Android tablet-based application electronic input of labor progress, cervical dilatation, and fetal head descent. This application can store all labor patient data and reproduce them as graphical images. The question is, can we rely only on a conventional partogram to assess labor progress? Vaginal examination is based on an individual assessment that is dependent on the tactile sensation of the examiner's fingers. It is considered to be a subjective technique and inconsistently reproducible. Furthermore, it can be painful and associated with an ascending infection. Assessment of labor progress by intrapartum ultrasound may play an important role in the management of labor and delivery. Ultrasound in labor was first recognized as early as 1977. Later, Transperineal technique was first described in clinical research in the mid-19s. The concept of a comprehensive multi-parameter non-intrusive ultrasound-based assessment of labor progress, known as the Sonopartogram, was first introduced in 2014. The image is a sample of Sonopartogram showing fetal head descent, cervical dilatation, and head rotation with explanatory ultrasound images. Assessment of fetal head position using transabdominal ultrasound is superior to vaginal examination. It is best performed by placing the ultrasound probe above the maternal suprapubic region in axial and sagittal planes. The marks depicting fetal occiput position are the two fetal orbits for occiput posterior position, image 1, the midline cerebral echo for occiput transverse position, image 2, and the occiput itself and the cervical spine for occiput anterior position, image 3. Transperineal ultrasound techniques used to assess fetal head station expressed as angle of progression and head perineum distance, also used to assess cervical dilatation, cavity succedaneum, and molding. Sonographic assessment of fetal head station is best performed by transperineal ultrasound. To measure head perineum distance and cervical dilatation, the ultrasound probe is placed transversely between the two labia majora, with the woman in a semi-recumbent position with flexed legs and knees and empty bladder. On transperineal ultrasound in midsagittal plane, several parameters can be measured, such as angle of progression, which is the angle between the long axis of the pubic bone and line from the lowest edge of the pubis drawn tangential to the deepest bony part of the fetal skull. Cavity succedaneum, which is the soft blotch of the subcutaneous tissue, can be felt as a swelling against the fetal skull, and molding is an overlap of the skull bones, as shown in the ultrasound images. Intrapartum ultrasound parameters have been shown to be predictive for labor outcome. In 2013, a prospective observational study performed in London included 400 singleton women at term were recruited before established labor. Fetal biometry and Doppler resistance indices were measured. Fetal Doppler assessment of the ratio between cerebral and umbilical Doppler has been suggested. It concluded that low Doppler ratio may be able to predict intrapartum caesarean deliveries for fetal distress in nulliparous women just prior to delivery. In 2015, a model with 120 nulliparous women have been recruited in 2 European centers. It was based on maternal characteristics and ultrasound measurements. It confirmed that the combination of maternal clinical and ultrasound characteristics could predict vaginal delivery. In 2019, a study recruited 315 women to investigate the differences in labor progress between vaginal and intrapartum caesarean delivery using transperineal ultrasound. Women who achieved vaginal delivery had greater changes of angle of progression and head perineum distance as expressed of fetal head station than those who achieved caesarean delivery. Recently, in 2021, a secondary analysis of prospective cohort study of intrapartum ultrasound was conducted in Iceland with 99 nulliparous women at term through the active phase of labor. In this analysis, angle of progression and head perineum distance were the variable greatest associated with operative deliveries. The intrapartum application based on the prediction model was published in 2015. This application was launched for research purposes only in 2017, suitable for Apple and Android mobile devices. It is the first birth prediction application created, which allows healthcare professionals to perform on-the-spot analysis for prediction of vaginal birth using specific maternal and ultrasound parameters. In our conclusion, previous studies have shown that integrating maternal factors, clinical findings, and ultrasound measurements can be useful in prediction of labor outcome. However, it is still the case that these predictive models haven't been fully tested in different populations and not yet ready for widespread clinical implementation. We believe that moving the scale from a passive recording of labor progress based on the partogram to the sonopartogram would represent a step change in a modern obstetric practice. The potential value of intrapartum sonography in clinical decision-making during labor